I really want you to be able to recognize quickly when you go in the room some of these very common diagnoses, and I am going to cover some basic ones, atopic dermatitis and seborrheic dermatitis, but show you the differences and really point out the nuances. I'll also discuss with you some of the new research that we're doing in these arenas because I think it is very exciting. I know it'll take a while to get here to Jordan, but there are amazing new medications coming forward in the arena, particularly of atopic dermatitis, but also in psoriasis. I want to help you be able to distinguish between a port wine stand and a hemangioma as well. We will discuss therapies, we'll discuss standards of practice, and again, updates. I don't have any conflicts of interest related to the discussion. I also really want to cover with you some of the pitfalls in diagnosis. If you haven't learned to look at what's called the primary lesion, then you can go off on the wrong path. When I gave my previous lecture on erythema multiforme, I showed you that target lesion on the palm. That's a true primary lesion. That is the hallmark of that disease. So those are key things that will help you tell one diagnosis from another. So we'll start with atopic dermatitis. I know many of you may feel frustration that we don't have anything that miraculously takes this chronic relapsing disease away, but I will say in the United States for patients 18 years of age and above, we have a new biologic agent named Dupixent that is nothing short of a miracle, except in its costs, which are astronomical, but it is a remarkable medicine that affects IL-4 and IL-13 and really shuts down the pathways that lead to the inflammatory cytokines that trigger atopic dermatitis. Many of my patients and parents express frustration because we don't have a way to take this disease completely away, although if you're 18 and above, the potential may exist now. Key things you want to look at. Does it spare the axilla and the groin? If indeed it does, you're likely in the right diagnosis. We usually see this beginning as early as 3 months of life, but classically about 90% of the cases you'll see start in the first year of life. So those are other clues you can use. It is more common if one or both parents are from another country and then their child, for example, is born in the United States. It can be a country even as close as Mexico, where if one parent has come from Mexico and the child is born or comes at an early age in the United States, the risk of atopic dermatitis goes up. Now, there are differences based on age that you need to clinically recognize and understand. In children, atopic dermatitis is generalized. It's all over the body, including the face. But as they get older, we tend to have focal disease, which includes the antecubital and popliteal fossa specifically. Now, we know that pruritus is the single most troublesome element that parents report to us is disrupting sleep, altering quality of life, and really disrupting the family, because if they don't sleep, no one sleeps. Here's a youngster, very young in age. He's a little bit erythrodermic. He has very generalized spongiatic dermatitis, and he's itching, so he meets all the criteria. He is really uncomfortable, scratching incessantly and driving his poor mom crazy. So the total body is virtually covered with eczema, and that is a good qualifier. Even his scalp has a lot of spongiatic dermatitis. So the child is very uncomfortable. He's not sleeping. Now, as children get a little bit older, they become more effective at scratching, as you can see here. They break the skin barrier. And keep in mind that these children are often colonized with Staph aureus. They don't have to have frank infection to be impacted significantly by Staph aureus, which just by its presence on the skin is a key driver of this disease state, making it much worse. This child has, as you will notice, marked erythema of both eyelids with swelling and edema. Why are the eyelids so uniquely affected in atopic dermatitis? Well, there really are two reasons. First, we have a higher rate of Langerhans cells, the antigen processing cells, in the eyelid compared to other skin body surface areas. Secondly, we lack lymphatics in the eyelids, so they're going to be uniquely prone to a bit of swelling. So this child does seem to have generalized atopic dermatitis, but if you notice in his antecubital fossa, it's especially marked there. His axilla are spared. It's a little hard to see. Again, as children get older, the disease pattern changes a bit. Here we actually have it on the front of the knee instead of the back of the knee. Kids never read the book on this, I say. Here's a smaller baby, very generalized, very widely extensive atopic dermatitis. Here, again, popliteal fossa affected because this child is better at the focal scratching as developmentally he has progressed. Here's a little girl that has Denny Morgan folds underneath the eyes, very characteristic of atopic dermatitis. Notice the dryness around the eyelids. Again, more Langerhans cells, so more reactive skin in that thin skin in that anatomic region. Here, her antecubital fossa with a slight fissure, probably colonized by Staph aureus. Here, widespread atopic dermatitis. A key thing I want you to notice about the primary lesions here is that they are really poorly defined. If you took a pen and had to draw around the lesion, you can't always detect where it starts and stops. The same is true here on the neck. Now, if you look at this neck picture very, very carefully, you find another primary lesion that is a driver of the disease. You can see a little molluscum up here, right there. There's an umbilicated papule, and again, molluscum love atopic dermatitis. Easy because it's broken skin, and it is another driver making the dermatitis worse. So is any infection, really. Here's another child very capable of scratching, antecubital fossa, lichenification, and poorly defined borders. Why do I bring this up? Because I'm going to contrast this with psoriasis, where the borders are well defined. One other component of lichenification, I want you to understand, for an individual to develop lichenification in the skin, they must scratch at least 140,000 times. You don't need to ask if this child is scratching or itching. You know by default just by looking. So here's another child with Denny Morgan folds, and again, the spongiotic dermatitis and dryness around these very thin-skinned areas known as the eyelids. Here's a child that's scratched so much she's become secondarily infected because she's compromised her border of her skin, and the interface again is altered. That allows the staph to adhere to her skin surface. Now, by comparison, adults also get atopic dermatitis. It can be generalized as in this case, and this patient has Denny Morgan folds as well. He does have widespread disease, but he's a more serious patient. And this is the unique population that can benefit tremendously from a new medicine known as Dupixent, which inhibits IL-4 and IL-13 and dramatically changes the path for those patients eligible and able to receive it. We'll go next to psoriasis. You may think that psoriasis is not very common in children, but that is simply not true. We see this all the time in children, but it's often missed. Here we tend to see the extensor surfaces primarily affected, the trunk and the scalp. We recognize the primary lesions as being erythematous plaques that have a very silvery scale on the surface. Even the youngest of children can have psoriasis. Some very capable pediatricians who referred to me on a regular basis called me and said, we've seen a lot of skin rashes, but we don't know what this is. Look at the sharp demarcation of this child. You may for a minute think it's atopic dermatitis, but you could easily draw a circle around many of these lesions. This is widespread psoriasis, not atopic dermatitis, and the treatment regimens can be slightly different, although topical steroids will help each group. This also is a plaque of psoriasis, very well demarcated, as you can see. There's no question about the sharp borders. This is a child who was in my office just a few weeks ago, very traumatized by the chronicity of the plaque psoriasis. The knees and elbows very commonly affected, and a great deal of itching can also be present with psoriatic plaques. Another child with a psoriatic plaque on the anterior shin. This is actually one of the most recalcitrant areas to therapy that we try to manage in the patients with psoriasis. Very thick scale. If one takes a piece of scale, lifts it off, there's something called the Auspitz sign, which means you get a little bit of hemorrhage at the skin surface because of the fragility of the skin just underneath the scale. This is also psoriasis, again, very well demarcated plaques, and this child is obese. Many of our children who have psoriasis unfortunately carry extra body weight, and this makes them ever more prone not only to the clinical cutaneous lesions, but also many of the comorbidities, including metabolic syndrome. Here's a youngster with plaque psoriasis involving the face. Again, sharp demarcation, differentiating it from atopic dermatitis. Some of my poor pediatric patients have such severe psoriasis involving the hands and feet that they really cannot do their daily tasks, including homework. These are patients who require aggressive therapy with systemic medications, including either methotrexate or one of the newer biologic agents, and occasionally both. This child had psoriasis also on the feet, which made simple wearing of shoes, athletic activities, and just daily activities like walking very challenging. Psoriasis can affect the scalp, and it is very pruritic, but notice the sharp demarcation at the edge. All right, we're going to next move on to seborrheic dermatitis, which is incredibly common. You may think that this is too simple to cover in such a conference, but I do want to cover some of the key things that you may find that make this diagnosis very recognizable. Now, compared to atopic dermatitis and a bit more to psoriasis, we see less psoriasis and atopic dermatitis in the axilla. That is where geographically seborrheic dermatitis likes to land. We see very little atopic dermatitis in the groin, although if the patient wears a diaper, we do tend to see psoriasis in that area, and you can see hypopigmentation. In the scalp, seborrheic dermatitis is classically felt to be under hormonal control. That's why we only see it because of the maternal hormones which have impacted the child for the first 6, 8, even up to 12, 24 months. After that, we usually don't see seborrheic dermatitis until the prepubertal point in childhood. Atopic dermatitis can have chronic scaling and itching during this entire period and is not impacted by endocrine factors. So this is seborrheic dermatitis. It's not psoriasis and it's not atopic dermatitis. You can see that there is greasy scale and it's in the groin and it's very commonly found in this location. Another example, although here we have well-demarcated plaques, and how can I distinguish this from psoriasis? Well, we will look in the axilla and we will see that there are matching changes there. They're not thick scale here as we would typically see in patients who have psoriatic disease. This patient also has psoriasis, and this is a darkly pigmented child who has developed post-inflammatory hypopigmentation as a function of this disease. This child has seborrhea involving the axilla, and this can be the real clue that you're dealing with seborrheic dermatitis when you match it with the changes we have already demonstrated and illustrated for you in the groin. This child also has seborrheic dermatitis with greasy scale in the axilla. This is not common for atopic dermatitis, although some children have overlap. Here's a third illustration with a slightly more pigmented patient demonstrating what seborrheic dermatitis looks like in the early days of life. Another child with more mild seborrheic dermatitis. This is got a little bit of hypopigmentation but not depigmentation. You need to distinguish seborrheic dermatitis from a more serious and life-threatening condition known as histiocytosis X. Here the child has recalcitrant seborrhea-like lesions, and this child will not get better despite very good, very vigorous anti-seborrheic interventions. This child warrants a careful physical exam and a skin biopsy in order to make the diagnosis so that appropriate therapy can be initiated. This child has what I would consider the world's worst cradle cap, the worst seborrheic dermatitis. Any child with seborrheic dermatitis of this magnitude absolutely should be evaluated for histiocytosis X, particularly if this patient fails to respond to normal anti-seborrheic dermatitis therapy. This child, compared to the earlier children that I've showed you, has really severe involvement of the axilla, and this indeed is histiocytosis X and falls outside of the realm of the primary lesions I illustrated for you with seborrheic dermatitis. Next, I want to distinguish for you the difference between erythema multiforme and urticaria. I find that the pediatricians I work with often are challenged with the aspect of seeing this in the emergency department or in their own clinic and there are many ways you can quickly discern which is which. Although these are easily confused, there are significantly different implications in patient outcome and how you're going to manage these. That each may be associated with drugs or infections. Erythema multiforme, as I illustrated in my previous talk, has fixed target lesions. They're fixed for at least 7 days, often on the palms or soles, but they can be anywhere on the body. There is classically no itching associated with erythema multiforme. The erythema multiforme lesions definitely may extend onto the lips, and then with severe forms, we get eye and mucous membrane involvement. Erythema multiforme really is a condition where we want to find the underlying reason that the patient has this, because if they take a medication, they certainly can have an even worse outcome on the next occasion that that medication is prescribed. So here is a child with the erythema multiforme. This is called almost an urticaria-like form of erythema multiforme. How do we know this is not urticaria? Well, one of the things you can do is take your pen and mark these lesions and see if the lesions move. You can also ask if the lesions itch. If there's no itching and there's no movement, you're dealing with erythema multiforme and not urticaria. Here we have fixed lesions on the palms. This is more consistent with erythema multiforme than urticaria. Here we have beautiful target lesions illustrated for you on the palms, and this is indeed erythema multiforme and not urticaria. In urticaria, the primary lesion is a wheal, not a fixed target lesion. This is another case of erythema multiforme involving the palm. All right. Urticaria, remember, will itch in most patients. The wheals actually move. They migrate over a matter of hours. The wheals also come and go, and the patients and parents can describe this to you. The wheals can cause swelling of the lips or the tongue and may impair breathing in severe cases. Classically, most urticarial eruptions will respond to antihistamines or even systemic steroids, although I don't like to use systemic steroids in this condition because the urticaria can come back and the patient will continue to want to have the steroids, but it's not a good option for ongoing therapy. Now, urticaria can be caused by drugs or infections, as I've suggested, but often, particularly your female patients, will have an asymptomatic urinary tract infection, and so it is worthwhile at least to do that test. You can also ask about indigestion. H. pylori infections, at least in the United States, have been associated with urticaria. And your patients think it's a really strange question to ask when they come in with a skin condition while you're asking them about indigestion, especially if you're a dermatologist. But you look really smart if you find out they have H. pylori and you prevent a GI bleed and you get rid of the hives. All right, so this is hives, and the hives are a little bit harder to photograph, and you can see at the upper portion, you see some wheals. Here also are some wheals, much, much harder to depict than erythema multiforme. These are a constellation of slide with wheals, and again, much more difficult to photograph, but I think you've probably all seen wheals in your clinical practice. This is a young lady who has significant urticaria. She did have H. pylori, and again, her parents thought I was rather clever that I picked that up and cured her by treating that. Let's go next to granuloma annulare versus tinea. These are two conditions that are often confused. And on the American board that is taken by the pediatric residents, this is a classic question always on the test. Granuloma annulare is characterized by a non-scaly, non-symptomatic eruption of small papules in the skin. It has a very poor response to many therapies. There often are single, but there can be many lesions present. This is not contagious. It is typically asymptomatic, but does cause cosmetic concern, and you can actually palpate the small bumps at the edge of the lesion if you stretch the skin. So again, hard to actually photograph, but this is granuloma annulare. It particularly likes the fingers and the dorsal hands, so keep that in mind. This is also granuloma annulare, and again, hard to photograph, but notice that there is no scale present on either of these clinical pictures. Granuloma annulare more rarely can take the form of small papules on the dorsal hand, but this is less common than the other forms that I illustrated. Let's look next at tinea, ringworm. Here, yes, this is tinea, which has central clearing and scale at the edge. This is infectious, it does itch, and it will be KOH positive. So if we want to look at tinea, this can affect the scalp. We don't see granuloma annulare in the scalp. The patients get this form of hair loss, which is easily recognized. They often have lymphadenopathy. This is where they have more inflammatory form of tinea capitis. This is a carry-on. If you just manage this with griseofulvin, you don't necessarily need to treat with concomitant antibiotics. This is tinea corporis, central clearing. You notice there's also some scale. Tinea corporis, central clearing, presence of scale, distinguishing it from granuloma annulare. You can have pustules with tinea. It's a little bit unusual, but it can be present. Here is scale, less evident central clearing, but you can see from the scraping this was going to be KOH positive. A perfect tinea lesion, scale at the edge, central clearing. Tinea underneath the breast, a very common place, even if you, especially if you have diabetic findings. This patient also has tinea. This is another example. Central clearing, scale, clearly distinguishable from granuloma annulare. I'd like to illustrate this for you at length. Another patient with tinea on the leg, tinea on the thigh, tinea all over. New kitten, also a key marker in your history. It's often the case for the patients in the United States. So we've distinguished those. Tinea versicolor will have spaghetti and meatballs on your KOH. I want to distinguish that from vitiligo. This will be Wood's-like positive, whereas your tinea versicolor will not. Staph scalded skin syndrome is one of the last things I'm going to discuss with you. This is increasing worldwide. It's been reported in the British Journal of Dermatology, so do be aware of this. This is distinguished from erythema multiforme and Stevens-Johnson. Notice the lips are spared. You must have a stratum corneum for the exfoliatoxin to have its impact for the patient to develop staph scalded skin lesions. And this is another child, more darkly pigmented, marked staph scalded skin. I think in the interest of time, I'll go ahead and stop here. I hope that these simple examples are helpful to you in recognizing primary lesions and distinguishing these dermatoses from each other. Thank you.